So the hip is a huge weight-bearing joint in the body, and a lot of the weight from the upper body is transmitted down through our hips. So the hip has to withstand a lot of forces. We talked about the bony parts of the hip, the osteology, and what helps keep that together. How do we keep the head of the femur in the acetabulum? Because it could just slip right out as we're walking. So we need to talk about what keeps it there. So one thing that helps stabilize our joints is ligaments, and the hip has an extensive ligamentous structure to maintain its stability. And we'll talk about the placement of the ligaments and why they're there. And the fact that the acetabulum is very deep and the head of the femur fits right in, that provides some stability. The muscles around the hip, we have big, strong muscles around the hip and tiny, strong muscles within the hip that help maintain some of that stability. So we're going to talk about ligaments in this section as the features of stability. And the hip in particular, it has internal ligaments and external ligaments and some internal and external supporting structures. So this is all about hip stability, this section. So for the learning objectives, I want you to really know the function of each of the major ligaments, the functional role. So normally when we talk about the functional role of a ligament, we want to know what motion does it limit. So all ligaments limit motion to some extent, and we want to know what motion is limited by a particular ligament. And then, you know, so what? So it limits some motion. How is that functionally important? Okay. So within the joint, there are some ligaments and some supporting structures. The transverse acetabular ligament spans the acetabular notch, which completes the cup of the acetabulum. So there are a lot of the ligaments sort of close up open structures in the bone, or they connect different structures. So in the osteology lecture, I talked about how some of the ligaments close up the sciatic notch. So the transverse acetabular ligament sort of completes the cup to sort of hold the head of the femur in there. When they do total hip replacements, they actually have to dislocate the hip in order to replace the components that are going to be replaced. So it takes, you know, physical dislocation to get the head of the femur out of there. And so they're kind of really destroying all these ligaments during the surgery. In knee replacements, you lose ligaments during the surgery too, and we'll talk about that when we talk about the knee ligaments. So the ligamentum teres is a tubular sheath of connective tissue that runs from the transverse acetabular ligament to the femoral head. So it's a little tube of connective tissue, and it carries a branch of the obturator artery through the ligamentum teres, and it provides some of the blood supply to the femoral head. So if you lose that ligamentum teres and you lose that blood supply, you could actually end up with avascular necrosis, where the bone actually dies off because it doesn't have a blood supply. And if you have avascular necrosis, you're heading for a total hip replacement, because when the head of the femur breaks down, that's kind of your only choice a lot of times. And when you have either hip arthritis or avascular necrosis, it results in significant mobility issues and pain issues. So a lot of the people I work with who have had total hip replacements, they tell me, like, oh, besides incisional pain and maybe some bruising right after the surgery, it feels a million times better than it did right before the surgery. So unlike hip replacements, where there's a few weeks of regret after the surgery because it's very painful in terms of recovery, with hip replacements, people are so glad they had it done because the pain issues are way better and their mobility improves a lot better too. So frequently, an older person, someone in their 70s or 80s, might be getting a hip replacement because of osteoarthritis. Usually a younger person, unless they have rheumatoid arthritis, but if they don't have either form of arthritis, they're often getting a hip replacement because of avascular necrosis. And I've worked with several, and when I say younger people, I mean like joint replacement young. So regular joint replacement age is, you know, late 60s, 70s, 80s. If you're in your 30s, 40s, or 50s, that's young for a joint replacement. So I say it's like joint replacement young. And so if you have a joint replacement young person, then it's likely that they had some sort of trauma in their past that caused an interruption of that obturator artery, and they ended up with avascular necrosis of the femoral head. So what happens is the head starts to break down, it doesn't fit in the acetabulum, and then you get, you know, grinding and unpleasant sensations going through the hip, and it significantly interferes with mobility. So even though these are supporting, stabilizing structures, there are other important functions as well. So still within the joint, another structure is the labrum, and you can think of the labrum as being sort of like a gasket. There's one in the shoulder as well. It helps deepen the cup a little bit. It's a ring of fibrocartilage on the outer rim. It provides increased hip stability by deepening the socket and gripping onto the femoral head. So if someone has a torn labrum, which is a, I wouldn't say common, but a not uncommon sports injury, is there anything we can do for a torn labrum in physical therapy? Probably not, but we can work on strengthening muscles for providing stability. We can work on mobility. We can work on pain-free range of motion. Usually with a torn labrum, people end up having to get surgery to repair it. And it's not commonly enough done that every orthopedic surgeon does it. So usually if you have a torn labrum, you're looking for a specialist who works with torn labrums. The articular cartilage covering the lunate surface of the acetabulum, and if you recall from the osteology lecture, that's the upper surface, which is really the weight-bearing surface on the femur. It acts as a shock absorber within the joint. So it's thickest at the superior pole of the femoral head. And doesn't that make sense? Because that's where you're bearing your weight. Again, articular cartilage is affected with osteoarthritis and rheumatoid arthritis. Even though in rheumatoid arthritis, it tends to affect smaller joints more, but not to say that it doesn't affect the large joints, but it also affects smaller joints. So those are the structures inside the hip. Outside the joint, we have lots of big, beefy ligaments. Because it's a big, beefy joint, we need big, beefy ligaments, okay? So the ligaments are commonly named, besides some weird ones like ligamentum teres. Most of them are named by where they go from and to. So ordinarily, you can think of ligaments, besides some weird specialized ones like the ligamentum teres, you can think of them as attaching bone to bone. So they're providing stability in the joints. And so all of the the external ligaments in the hip joint are named by where they go to and from. So the iliofemoral ligament goes from the ilium to the femur. Doesn't that make sense? It's a Y-shaped ligament, so it has a single attachment on the ilium, and it branches out into two legs like an upside down Y, and attaches on the intertrochanteric crest, or the intertrochanteric line, excuse me, the crest is posterior, in the anterior part of the hip. So it's thick and strong. It is that inverted Y. It attaches on the anterior part of the hip. And when you look at the lineup of the ligament, you can see that it can limit excessive extension of the hip. So when the ligament is on slack, when your hip is flexed, when your hip goes into extension, the ligament goes on stretch. And so ligaments are pretty firm. They don't have very much stretch to them. So it limits excessive extension of the hip. Okay, we'll talk about why that's functionally important in a couple minutes. So the ischiofemoral ligament, just like it sounds, it goes from the ischial portion of the acetabular rim. It spirals around the femoral neck and attaches near the apex of the greater trochanter. So we get this spiraling effect, and that has a stabilizing effect as well with the ligaments. So you can see in this picture, the ischiofemoral ligament is posterior to the two branches of the iliofemoral ligament, and they're sort of spiraling around the head and neck of the femur to provide that anterior stability to the hip. Ischiofemoral ligament also limits hip extension and internal rotation of the hip. And if you look at sort of the line of the ligament, you can see how it would limit internal rotation of the hip. It's a little bit posterior. And so in order to internally rotate, the anterior surface of the bone has to move medially towards the midline of the body. And that ligament is opposing that action. So it limits extension and internal rotation. The pubofemoral ligament, as you can tell from its name, goes from the anterior inferior rim of the acetabulum and attaches the pubic rim of the acetabulum and attaches to the lower half of the intertrochanteric line of the femur. So, and it limits abduction, abduction, and you can see that from its line, how abduction, the femur is going to go away from the midline, and that pubofemoral ligament prevents that, and also extension of the hip. So all three of those big, fat, beefy ligaments limit extension of the hip, and we'll see why that's important. But that's what you want to know. You want to know the name of the ligament, where it's located, and what motion it prevents. So all three of iliofemoral, ischiofemoral, and pubofemoral ligaments prevent excessive hip extension. They limit hip extension. Ischiofemoral has a side job where it limits internal rotation, and pubofemoral has a side job where it limits abduction. So this is a diagram from the book, and in our normal standing position with good upright posture, the line of gravity is just posterior to the medial lateral axis of rotation of the hips. Okay, so you can see that if that line is a little bit posterior, we have a passive extension torque at the hip. So if that wasn't opposed by those three ligaments, the pelvis could bend backwards over the femurs. It doesn't, though, because you have those three ligaments, iliofemoral, ischiofemoral, and pubofemoral, preventing that extension. So we can sort of lean into our hip ligaments a little bit and stand for a long period of time using minimal amounts of muscular energy. What a good function that is, right? So conserving energy is one of our body's main things it wants to do. It wants to save our energy for when we need it. So if we use up all of our energy just standing there, we're not going to have any left to do things that we need to do. So we'll look at that, what happens. So here is another instance when that could really come in handy. So all of those three external ligaments are stretched in extension. So we'll often talk about whether ligaments is on slack or on stretch. So when it's on slack, it's not doing anything. When it's on stretch, it's limiting a certain motion in the joint. So ligaments generate a passive flexion torque at the hips. So those three ligaments, they're limiting extension and they're kind of pulling you forward a little bit into flexion. The tension between the stretched ligaments of the hip and the action of gravity allows us to stand without using a lot of muscle. So here in the picture, it depicts a person who has paraplegia. So they don't have a lot of muscular force in their lower body, in their legs, but they can stand with the aid of braces at the knees and ankles, and leaning the trunk and the pelvis posteriorly relative to the hip joints, stretching those ligamentous structures that are preventing hip extension. And the Lofstrand crutches that the individuals using this picture are for balance. So you provide that passive flexor torque at the hip, and that stabilizes the hip and pelvis, allowing that person to stand, because they don't have the muscle force to do it in their legs, but the hip ligaments are letting them do that. So if you have someone who uses that mechanism to stand, you probably don't want to do a lot of hip flexor stretching, because you don't want to stretch out those ligaments any more than they're already getting stretched out, because muscles can stretch and rebound. Ligaments, once they're stretched out, you know, if they're overextended, they're not going to stretch back. So we're probably not going to be doing muscle work with this person, because they don't have innervation to their muscles. We're looking for standing stability using the structural components of the hip rather than using the muscles to do it. So if someone has a hip flexion contracture, meaning their hip flexors are limiting their passive hip extension because the muscles are shortened for whatever reason. They might be shortened because the person sits all the time. They might be shortened because the person has Parkinson's disease. They might be shortened for some other reason. So when a person with a hip flexion contracture attempts to stand, that passive standing mechanism is disabled. So it results in the need for continuous activation of extensor muscles in the hip and the back to maintain an upright position. Well, how much energy does that take? That takes a ton of energy. So that is a consideration when we're working with someone who, for whatever reason, has a hip flexion contracture. I work with a lot of people with amputations and working on prosthetic training and gait training with a prosthetic leg. So if someone with a prosthetic has a hip flexion contracture, you can do some adjustments on the prosthesis to shift that line of gravity posterior to work on their balance. But you also want to work on stretching those hip flexors and making the hip flexion contracture less or getting rid of it. So eventually they can stand upright, because they're going to get much better use of their prosthesis and much better weight bearing through the residual limb if that's the case. So it's really, I love working with people with amputations, because you really have to think through the mechanics and what's working and what's not working. So there's a lot of problem solving that goes on in every session, and you always want to take off the prosthetic and inspect the residual limb every time to make sure you're not getting excessive friction or weight bearing on surfaces that aren't meant to have weight bearing. So in the design of the prosthesis, it's very individual to that person, and the person who's designing the prosthesis has to decide where they're going to bear weight and what are the intact skin surfaces and bony areas that they're going to be bearing weight on. And if there are areas that can't tolerate that weight bearing, it can cause a lot of discomfort and make it so it's not comfortable to walk in the prosthesis, or not functional to walk in the prosthesis. So knowing the hip mechanics is super important for coming up with the right PT treatment for these people. The other population that you work with a lot in PT, no matter what setting you work on, is elderly people. So take a look at your favorite elderly person, and you'll see that a lot of them have a tiny little bit of hip flexion, tiny little bit of knee flexion. Okay, that takes a lot more energy to stand that way than it does being able to get the hips and knees straight and the line of gravity slightly posterior to the mediolateral axis of the hip. So for elderly people, it might take a lot more energy to do regular tasks that it doesn't take for a younger person. So that is something to consider when you're asking elderly people to do things. How much energy expenditure are we asking them to make?